So Christy, this is all the information I'm giving you so far about this patient. What recommendations do you have for this patient?
So I would want to go back and look at past labs. Is this his first A1C of 6.5%, or is this his second or third one? Does he have any other fasting blood sugars that are in the diabetes or in the pre-diabetes or diabetes range? If this is his first A1C at 6.5%, this does not constitute a new diagnosis of diabetes. We would have him come in, maybe be with a dietitian, let him know that he could make some changes in his diet, get a good diet history, and maybe look at making some changes in his diet to bring his A1C down, maybe shoot for a 5 to 7% weight loss, bring his BMI down into the normal range, and then recheck everything in about 3 to 4 months.
All right. Dr. Lynn, what would you add?
Yeah. All right. Yeah, I would agree. Since the patient is, yeah. All right. Yeah, I would agree. You do need to confirm the diagnosis, and really giving the patient a chance to improve. Their lifestyle likely will probably delay the diagnosis of diabetes. The other part is probably reviewing family history. Since he's young, you always think about possible type 1, even though he probably, he would react very differently, but usually family history on the first visit is very important. And but otherwise, yes, I agree. Confirming diagnosis is very important.
All right, excellent. Let's see what's in the top basket for Christy. Oh, a regular soda can. So your educator went in to see Otto, and your educator discovered that Otto is drinking 6 regular sodas a day. Would that fine tune your approach? How would that change your approach?
That would still, how much can we get him to give up on the sodas? Even if we can drop it to 2 to 4 cans a day, that would probably help with his A1C. See if he's actually willing to fully give it up. But sometimes they have a hard time doing that. So meeting them somewhere in the middle, and then again, rechecking stuff in a few months.
All right. You have your own chopped item, Dr. Lynn. Let me find it. Your chopped item is a family tree. And the patient has a strong family history of diabetes. What other, and autoimmune diseases in general, besides type 1, is there anything else you might screen for?
Yeah, we do ask what part of Alaska their family origins from. Their specific autosomal dominant MODY gene for diabetes that we do track. And so if the patient is from that area or has, family that we have known, family member with MODY, we would definitely test him early for genetic diabetes.
All right. So let's see if I can wake my remote up. As Christy alluded to, and Dr. Lynn, for diagnosing diabetes, we are looking for 2 fasting blood sugars above 126, 2 A1Cs above 6.5, random or an oral glucose tolerance test above 200, or a random above 200 with signs and symptoms. Usually those are confirmed on 2 different days to formally diagnose someone with diabetes. Healthy lifestyle behaviors, diabetes self-management, education. For someone young, pretty close to goal, this is where we would likely start on the algorithm from ADA kind of for the recommendations for therapy. So I would like to invite attendees to a mic. My mic runners are getting up and ready to go. What else might you do for Otto, or other approaches you might take with this patient? It's early. Anyone chatty this morning? Now, none of these dietitians in the room are going to say we should have referred him to a dietitian. Okay. Oh, yeah. I got a thumbs up, but she's still not going to talk to us.
I see that he plays basketball regularly, and I think with something that may be a new diagnosis, it's always important to offer a lot of encouragement too about things that he's doing well. So I'd want to offer support and encouragement for his physical activity and ask about frequency.
All right. All right. I like that. Frequency of physical activity, positive reinforcement for the behaviors that we love to see in our patients. Oh, I see a hand up. I love it.
Sleep and stress management.
All right. Interested in knowing more about sleep and stress management. Always good information to have. Does Brandon want to talk too? It's rough if you're in the audience and I know your name.
Given the fasting glucose and A1C, I'd be curious if the CBC was done to check for any hemoglobinopathies.
Dr. Lynn, do you want to speak to how the CBC would influence those measures?
Yeah, I think given the history that the patient, I guess, has a family history of autoimmune disease, but if the patient has history of, young childhood cancer or whatnot, if they have history of chemo or whatnot, those will affect healthy hemoglobin, and then the A1C may not be as accurate. The other part I wanted to kind of bring up is this may be the patient's first time kind of to a healthcare kind of contact or whatnot, and kind of just introducing what is glucose metabolism, kind of learning what, I guess, health literacy, educating the patient about what is diabetes, and he is possibly at risk, if the A1C is real, and just to kind of be aware of that kind of disease education is also important in their first visit.
Thank you. Anything else from the audience or Christy or Dr. Lynn to add on case one? All right. Chopped. Standard of care. Round two. I love pictures. You like my pictures? Look how cute that is. That's so cute. We had enough providers we could kick them off the stage like they do the chefs, but we're going to keep them because they're, anyway. Round two, antibodies. Auntie is a 36-year-old female. She's had diabetes for 2 years. She's referred to diabetes specialty clinic from her primary care provider. Her current A1C is 7.7. She's on metformin, 2,000 milligrams daily, Ozempic, 1 milligram once weekly. She doesn't miss her doses. She's very consistent in taking her medication. Auntie's BMI is 32. Dr. Lynn, where would you start with this patient when you meet her in diabetes specialty clinic?
Kind of her relationship with the diagnosis of diabetes first. In the last 2 years, what has she perhaps changed or not changed since her first diagnosis, other than taking her meds regularly? And really her lifestyle. What is her sleep-wake cycle? How busy she is in her daily kind of activity. Can she get her eating patterns? Usually a 36-year-old female, I would kind of look for eating patterns or distress eating and such. With her BMI, how she feels about her BMI, her weight. Is she happy with her weight? Does she feel it's a healthy weight for her? And kind of start there. Again, always focus on lifestyle, especially a 36-year-old. What's her mobility capability? There could be someone, 36-year-old with arthritis, rheumatologic arthritis that can't move very well or whatnot. So those are something I would start with. And if she checks her sugar, again, what's her relationship with her diagnosis?
All right. As anticipated, Christy, what would you add to Dr. Lynn's approach, or what kind of things would you think about when you see this patient in clinic?
Again, just kind of figuring out where her thought process is with it and what her lifestyle is at home. Trying to see if it's something with medication or lifestyle that we need to work more on.
All right.
All right. Past medical history.
All right. So Dr. Lynn, from the chop basket for you, we have a baby toy. What could that mean? As it turns out, Auntie has 2 kids and is currently trying to have a third with her partner. They have been trying for 2 months. How might that impact your approach for caring for her?
I would definitely focus on making sure, like talking to her about getting her A1C less than 6.5 before really trying for conception. And the other part is talking about Ozempic, as if she's actively trying right now, we would stop Ozempic immediately and then likely switch over to insulin if her blood sugar is still not well controlled on metformin alone.
Dr. Lynn, can you
likely.
share with the audience what the recommendation is for stopping Ozempic?
Oh, so for right now, for pregnancy, really only Ozempic and sulfonylurea and insulins are recommended. Ozempic, ideally, we would stop 3 months ahead, 2 months, 2 months ahead before they're actively trying. And so, yeah, so if they're actively trying right now, I would stop immediately.
Christy, anything to add before I get your item from the chop basket?
So when I start seeing these women who are coming in and saying, I'm trying to get pregnant or I want to get pregnant, I go over the A1C recommended less than 6.5. But I also say this is what to expect once you become pregnant. And that is when you become pregnant, your goal blood sugar is no longer less than 120 fasting. It is now less than 95 fasting. And now we are also going, once you become pregnant, we're going to ask you to start doing finger sticks 4 times a day because you need to grab that 2-hour postprandial. And we want either a 1-hour postprandial less than 120 or a 2-hour postprandial. Hold on, let me reverse that. 1-hour postprandial less than 140 or a 2-hour postprandial less than 120. And that during pregnancy, we will use insulin to manage you. And so I kind of give them a rundown of what to expect if they haven't had diabetes through pregnancy in the past. So that way they're not shocked. Once you go on insulin, I'll say we offer you a CGM, but maternal fetal medicine, FYI, don't care much for the CGMs. They will require you to do the finger sticks. So the CGM is an adjunct to the finger sticks, not a replacement for the finger sticks. Those finger sticks are still required.
So Christy, if this patient had 2 kids at home, had tubal ligation after her last pregnancy, but really was just in clinic to see us to help get her A1C to goal, what might you offer her?
So she's had a tubal ligation and we're just working. She's on metformin, she's on Ozempic.
Yes.
And then we're going to add something in to bring her A1C down. Probably talk to her about how did you tolerate Ozempic 1 milligram? How do you feel like this is still suppressing your appetite? Have you had much weight loss with it? To consider going to a 2 milligram dose on the Ozempic. And then I do decide how fast we'll go up to the 2 milligram dose based on how well they tolerated the 1 milligram dose and titrating up to that. Say they're on the 1 milligram dose and they're still having some issues with nausea a day or 2 after the injection. They're really restricted on their food. And that would be signs that I wouldn't want to increase the Ozempic because all the symptoms are going to do is get worse and then they're going to decide to quit taking it. Other thoughts, next first line, I would actually start Jardiance or empagliflozin. Of course, reviewing with them, increase your water intake, limit your sugary beverages, and discussing possible signs of increased urinary frequency and possible yeast infection, urinary tract infections, just to kind of keep an eye out on them. If you do get them, please give us a call. We'll get them treated. Don't let them wait.
All right. Let's see what your chopped item is, Christy. We have an empty water bottle.
Does this mean she doesn't drink anything?
It turns out Auntie lives in she lives in a rural area, doesn't have easy access to running water, and this makes staying hydrated hard for her.
So Jardiance may not be the best option. So then that does kind of, as long as she was tolerating the Ozempic 1 milligram, then that would be optimal.
Let's make it really hard. And she's can't go up on the Ozempic. She lives in a rural area where she's not going to be able, doesn't have easy access to water. How does the conversation go with the patient at that point?
So from there, we start really looking at lifestyle. What are you willing to cut out? Let's say she was mostly drinking sodas or, quote, juice, which tends to be tang. Then I would be like, can we try to cut some of the sugary part out? Otherwise, I will go through a medication list and say, so we know you're maxed out on metformin. Ozempic, you're not really tolerating. You're tolerating the 1 milligram, but it's questionable if we can do the 2 milligram. Jardiance isn't the best idea. So let me go over some other meds we have. And these are our other meds. We have sulfonylureas, which are not my favorite, but they'll help cover those mealtime sugars. They're going to really increase your risk of hypoglycemia. We've got Actos, but that may cause you to gain weight. On average, about 50% of my patients I put on Actos or pioglitazone, they're going to put 15 pounds on in the first 6 months. That tends to be where it stabilizes. They have a really hard time pulling it back off again. Or we can also look at basal insulin, and we could just add in a once-a-day shot to titrate it on their fasting blood sugars and see if that could finish bringing her down to goal.
Thank you. All right. Yes, please. Add away.
Maybe this patient is in a region where they have tirzepatide. I would switch her over from Ozempic to tirzepatide and titrate it up, or use outside pharmacy or Trulicity. There are other GLP-1s. If they don't tolerate Ozempic, we will try. And with Trulicity at 4.5, it also has pretty good weight loss and A1C profile. The other part is considering CGM. Again, just kind of letting the patient seeing how their lifestyle is affecting their blood sugar trends and stuff may be helpful. But and taking that back to tirzepatide, also if she's trying to get pregnant, that would not.
We can pretend she's not pregnant for a while. Because I think the audience might be interested in your experience with patients who haven't tolerated Ozempic and you've tried them on Mounjaro.
Yeah, so with Mounjaro, we have a lot of success, even at lower dose. For me personally, I would do like Ozempic 1 milligram. I would probably transition them to about 5 or 7.5, and then we tell them, if you tolerate this, we actually have room to kind of go up on the dosing as well. And Trulicity, I'll probably transition them to about a 3 milligram weekly. But again, these are just how I do it, and then we kind of titrate up or down. I think, so that, and we have patients actually have really good response really well with tirzepatide, a lot of weight loss, even just at 5 milligram. Like there are patients that just kept it about 5 or 10 milligram and not titrating all the way up to 15. Of course, cost is a big issue. We have patients where at higher dose, the cost is higher monthly, unfortunately. But we definitely try that if they're not tolerating Ozempic well. And Trulicity is really good, especially for a young patient with no ASCVD history. It's actually a very good primary prevention for ASCVD in the GLP-1 category of medications.
Yeah, so the section of the algorithm we have highlighted right now is for if the focus is glycemic control and weight management, which might be our focus with this patient if she wasn't planning to get pregnant. But if she's planning to get pregnant, there's just some real specific recommendations from the American Diabetes Association. Potentially harmful medicines need to be stopped prior to planning. The most common medications that we see in our diabetes patients would be the GLP-1, GIP combinations, ACE inhibitors, ARBs, and statins are typically the medications that will need to be stopped when the patients are planning conception. So what else from the audience, if you guys want to take a mic, what else would you think about in this patient, both if they are planning conception or if they are not planning conception. Other approaches you guys might take? Oh, I see a hand. Uh-oh.
We have a question from
Yes.
the chat.
Oh, a question from the chat. How exciting. I forgot about the chat.
So the question is, why 2 months off of Ozempic when a person is trying to conceive? Is the drug still active in the body for that long?
Yeah, so the half-life of Ozempic is about 7 days. So it does take 6 to 8 weeks for it to fully get out of the body. And I will say that in practice, when somebody stops Ozempic, you will gradually watch those blood sugars inch up over the course of about 4 to 6 weeks. You watch those numbers gradually increase as it gets out of the body. So they'll be like, oh, I stopped it. I didn't take it for a week. My sugars are still good. And I'm just in my head going, yeah, let's see what it does in another week or two. Because it goes out, the sugars go up. But
Teresa in the back.
What about considering strategies for weight loss specifically, whether medication assisted or something else?
Sorry, what was it?
Strategy for medication assisted weight loss.
Medical, like when they're on like Contrave or
Yeah, exactly. Yeah, something like that.
Yeah, so that with so if the patient, yes, is very interested in weight loss, that would definitely be considered. However, we don't. I guess we would then ask the patient to obviously monitor their blood sugar very closely. And so, yes, you're right. Then in that case, perhaps we do not need to increase Ozempic, semaglutide to a weight loss dose or anything. But yes, I do address if they're interested in medication to help with their weight loss, bupropion, naltrexone, and all these things. And if they have other things that they're also considering, like nicotine cessation, those are good kind of combo options. If they also have alcohol use, naltrexone is great. And I think some THO has like Contrave formulary, which is the phentermine.
Contrave is
Wellbutrin.
bupropion and naltrexone.
Okay, not that one then. But
the other one is Kismia, and that one I've done where we have Topamax on formulary and phentermine is dirt cheap. And so I will send them a phentermine prescription to an outside pharmacy for 15 milligrams and then titrate them up on the Topamax as tolerated, checking in with them initially at 30 days. And then from there, I'll push it to 3 months out, having them come in every 3 months for a weight, a refill on the phentermine, because I'll put 3 refills on it, and to see how they're doing with it.
Audience, what else would you do? I thought I saw a couple hands.
Right.
Yeah, so an endorsement from the audience for CGM to kind of fine tune recommendations. And Teresa?
I would just ask what it would take to increase water intake.
Yeah. So, inquiring what it would take to increase water intake, I'm assuming that might be because you would advocate for Jardiance if we could make it work in this patient. Okay.
I just want a few more labs. Like, has she been on metformin greater than a year? Shouldn't we be getting some CMPs, vitamin B12, checking some of that stuff too?
You can speak to when you would want to check those things, or you can make up the results and speak to that.
So typically on metformin, I will get a B12, CMP, CBC, A1C lipids annually, typically on my people with diabetes. And then depending on what those results are, we'll adjust. Do we need them every 3 to 4 months versus 6 months versus annually?
Yeah, I want to speak on the CGM, and that's great if patient is checking their blood sugar or if they're on a CGM, like we give them target, like what they're looking for, right? Like what is too high, what is too low. In our younger patients, I do ask them like your fasting blood sugar should be less than 120 instead of the 130. Your postprandial should be less than 150 instead of the 180. Just because you're younger, we want to target like A1C lower versus if this is a 70-year-old, then our target would be higher. So it's always good to kind of let the patient know what when they're the speaker yesterday. We have so much data, but we need to kind of tell them how would you respond to this, and what are the things that they could do to kind of try improve it, and maybe like have them think back, what do they have for dinner the night before? Maybe that's why their morning blood sugar is higher. Or do they have some? I asked my patient, do your family member maybe notice that you're like sleepwalking or eating? Like, are you in the kitchen in the middle of the night? Like, they just don't remember that they did that in the middle of the night. So, sometimes when you don't ask, like, you don't find out that they have, different habits, eating habits.
Anything else the audience would like to add regarding antibodies? All right, I don't see any other. Okay, thank you. Audrey, could you read that question for us? I appreciate our mic runners.
Same person. Do you see weight gain with Actos less than 30 milligram dose, or is this more with the 45 milligram dose?
I see it with all lactose dosing, and I don't find that it's dependent on the dose. I put them on 15 milligrams, they're going to gain the weight. I put them on 30, they're going to gain the weight.
I do like to advocate for Actos. I know it has bad weight gain profile, but it's patient dependent. I always tell them, let's try. We have patients who tolerate great, and it really improved their insulin sensitivity. It's great for liver, fatty liver disease. So I would still try it, but I do warn them, you could gain weight, you could have lower extremity swelling, but yes, it's not really dose dependent. We just try it when you have nothing else, that it doesn't have a hypoglycemia
I feel like I've seen
risk.
some super responders to
Yeah.
pioglitazone too.
We have
Like,
people who
the
can
literature
agree.
doesn't say it decreases A1C 2.5%, but I swear I've seen people who are just like amazing responders to pioglitazone, even though it's not usually one of our go-to medicines. All right. Anything else on Miss Auntie? Okay. Round 3 of our standards of care chopped challenge. All right. Let's see who our case is. So macrovascular is a 57-year-old male. He is admitted to the hospital for shortness of breath. And while he's there, he's found to have diabetes. His A1C is 10.1. His point of care glucose was 316. He has an LDL of 128. He's a smoker at about 4 cigarettes a day currently. His BMI is 31 with a weight of about 105 kilograms. He is discharged from the hospital on Lantus 20 units daily, and a sliding scale of 1 unit to lower his blood sugar 50 milligrams per deciliter when it is above 150. Mac brings home blood sugar logs to his post-discharge outpatient diabetes appointment. So how it goes. Patients getting discharged from the hospital. The inpatient hospitalist wants them to follow up in diabetes clinic in 1 to 2 weeks after the visit. This is what Mac brings to his outpatient follow-up appointment. We'll say he sees Christy. Christy, how would you start your visit with Mac?
Okay, so I'd start out finding out his kind of past medical history, diabetes in the family. Also, when he was admitted with this newly found diabetes, making sure that it was not in a DKA type scenario, because you can have type 1s that do present in their 40s and 50s. I think the oldest I've seen was 59 as a brand new type 1 diagnosis. So that is something to keep an eye out for. I would find out if he's been losing weight leading up to that admission, or if he had been relatively stable and if he had had any symptoms of hyperglycemia leading up to admission, because this is going to affect how fast I'm wanting to bring the insulin down and get him off of insulin. I want those symptoms to completely resolve before I look at really trying to decrease the insulin. When I look at his blood sugars, looks like we have some room for improvement, but basically definitely looking better than that A1C of 10.1 when he was admitted, which tells me he's had blood sugars pushing around 300 for the last 3 months. I would find out about the smoking, what's his plan for stopping, also lifestyle, beverages that he takes in during the day, water intake that he takes in, what's his eating lifestyle like. I'm particularly interested in what he's having for breakfast because his 2 hours after breakfast are really high. So I'd be curious what he's having for breakfast. Typically in these scenarios, as long as they don't look like they're a LADA or a late onset diabetes type 1, then I start looking at Ozempic. That means that we've got to, or another GLP, depending on what tribal health facility they're from. That means we got to make sure there's no pancreatitis, no history of ME in the family, medullary thyroid cancer. I'm not worried about papillary thyroid cancer, just the medullary thyroid cancer. And as long as we're negative on those, then I'm going to start talking to him about a GLP. Most of the facilities have Ozempic. That's usually where we start. And then I would start him on a titration with Ozempic, 0.25 for about 2 to 4 weeks, and then increase to 0.5 as long as he is tolerating it. Lots of education on possible side effects and what he needs to do with his diet, including lower his fat intake, smaller meal sizes. I usually say instead of using a large plate, go to a salad plate just to reduce your serving portions naturally because you don't want to eat around the Ozempic. That'll increase your risk of side effects. And as long as tolerated, then we'll work on getting him up to the 1 milligram. Along with that, I would take away the sliding scale. I do not like these sliding scales they get discharged on. The Ozempic's going to help cover the meals. We're also going to have him meet with an RD to work on what he can do with that breakfast at least. And the Ozempic will also help cover the postprandials. And then as these sugars start to correct and that hyperglycemia starts to kind of in a system, starts to correct, the pancreas will start making insulin more efficiently again, and we'll probably be able to get him off the Lantus. Metformin's a possible add-in. I'd be curious, though, to try to get him off on the Ozempic and off the Lantus before just throwing him on the metformin. But metformin's a possibility. But you've got GI side effects with that, and I'd rather him on the Ozempic.
Dr. Lynn?
I would ask like kind of his hospital course if he was on steroids, prednisone for shortness of breath, if it was a COPD exacerbation or asthma exacerbation, maybe that just kind of to evaluate his insulin needs. However, of course, with A1C, assuming he has a good hemoglobin, that is a reflection of 3 months ahead. And so, but yes, he will need to be on an injectable. He might need on a little, yeah, I agree. Like with a sliding scale, I think it's very difficult to do it outpatient for them, even though they're probably really motivated to do it maybe initially. But yeah, Lantus, I agree with Ozempic. However, if he has a good renal function, has good water supply and intake, I do like to start Jardiance, assuming he's not a type 1 or insulin deficient patient that empagliflozin, SGLT2 inhibitors. I do like to start them early in my younger patients where their renal function is still good to kind of get them on it. And it's also looking at his weight and BMI. He can lose some weight, but you know, again, I always ask, like, do they feel healthy with their weight? Do they want to lose more? Yes, if they want to lose a lot more, Ozempic is a great option for their blood sugar and weight loss. SGLT2 inhibitor is also a good kind of weight negative medication. And that's kind of where I would consider start him on that with the Lantus. It has the same effect in kind of improving postprandial hyperglycemia as well, assuming they can keep up their water intake. Also, because it's a male, the UTI and yeast infection risk is slightly lower than female, but it can happen. And so that's why this is kind of the patient that I would try to get them on the SGLT2 inhibitor sooner than later. And yeah, I would probably, when I first see him, assuming he's no longer on steroids or anything for his respiratory issue, I would probably go up on his Lantus a little bit and then add a SGLT2 inhibitor and stop the sliding scale Novolog. I would definitely ask him his interest in stopping smoking and if he has any history of cardiovascular disease, statin if he's not already on one with his LDL, and definitely cardiac risk. Usually for their first visit, I would if they're especially over 40 years old, I would do the SCVD 10-year risk calculator and kind of review that. And then the other part is, yeah, and then kind of recheck, kind of same thing, like making sure, since it's a first visit as well, kind of family history and making sure it's not a type 1 like DKA presentation in the hospital. Sorry, I want to go back also to the prior case. I totally forgot we're doing standards of care. Also, like, because for young patients, since like usually it's not a lot of medication kind of like this, you just want to make sure you're asking them like eye retinopathy screening, dental, foot exam. Those are at least annual. And then for younger patients, contraception, but I guess if she wanted to get pregnant or not. If it was an 18-year-old like first patient female, I would definitely talk about contraception and family planning when they're first a year office.
So let's say Mac started Jardiance or Ozempic and had a lovely response to it. There are lots of different ways to titrate up and down on the Lantus. What are your kind of standard instructions you give to patients for those titrations?
So my standard instructions with any of the basal insulins is we actually have a nice pretty chart with instructions at the top. And so I'll usually, if you're greater than 130 for 2 days in a row, no, 3 to 4 days in a row, greater than 130 fasting, then you can go up by 2 units on your Lantus or Tresiba or Levemir, whatever the basal insulin is. However, if they're less than 100, especially if I'm really trying to get that insulin off because they're on Ozempic, if you're less than 100 for 2 days in a row, then you can decrease it by 2 units. If I have somebody who's a little bit that's elderly and we're not shooting for as tight of an A1C, then I'll give them the upper end of 150 versus 130.
Yeah, so for this patient, if this is first diagnosis, sorry, that's the other part, I would be very aggressive in trying to bring their A1C down to as normal as possible, less than 7 in a 57-year-old. Unless you, of course, look back, if they have another A1C, maybe they just never told a patient like it was 8 or something, they actually had diabetes for years, versus if this is a brand new diagnosis because they were sick for months and then, for a few months and then A1C is elevated, I would actually be very aggressive trying to bring their A1C quickly, well controlled, because again, complication is time in hyperglycemia. So the longer you leave them with their tolerable A1C, they're more likely to have a cardiac or cardiovascular event in the future. And so, yeah, so for him, his A1C goal, I would look for less than 7. I would give him like very specific instruction. Your fasting blood sugar should be, in this case, less than 130. That's what you're looking for. And up titrate or down titrate your Lantus accordingly. Usually I say less than 80 to reduce 2 units. And then greater than 130 for 3 days in a row to increase 2 units. And I would give them a max dose. Okay, like they need to be calling us if they reach like maybe like 40 units, like something is not right. Why are you needing so much Lantus daily?
Thanks. All right, Christy, from the chop basket, your mystery item is a calendar. Mac works 2 weeks on, 2 weeks off on the slope. He wants off insulin because he has a CDL.
You do not have to be off insulin to have your CDL.
I knew she was going to say that.
I still get questions from patients or refusing to go on. Well, actually get referrals. Patient has a CDL, A1C 9.5%. They're on Jardiance, Ozempic, metformin, and they are refusing insulin start. So I do let them know you can be on insulin. The National Truck Drivers Federation that manages all of that back in 2018 actually came in and ruled that you can be on insulin without all the special federal regulation exemptions, where they have to see an endocrinologist and you have to start the paperwork 3 months before, and you have to do this every year. I remember doing this paperwork when I worked in North Carolina. And So it's actually a simple 2 or 3 page form that whoever's treating their diabetes goes through, fills it out, sends it to whoever's doing their CDL. If you're the primary care provider that happens to be doing their CDL and you manage their diabetes, super easy form to fill out. You sign it, does not require a specialist. The biggest thing is plan in place for hypoglycemia. So maybe you throw them on a CGM that has an alarm on it, especially when they're out on the slope or when they're driving, or they have a glucometer that they carry with them so that they can check their fingers, and then making sure that they have a plan for treatment of hypoglycemia where they have glucose tabs or some other snack, 15 grams of carbs in the truck available in case they do have a low on the insulin. I do have type 1s that have CDLs. It's not an issue getting them certified.
All right. Dr. Lynn, your mystery ingredient from the chop basket. It's an empty bottle of alcohol. When Mac is in town on his 2 weeks off from the slope, he likes to enjoy what might be considered an excess of alcohol and can sometimes drink up to 8 servings of alcohol on the weekends when he's in town. How does that change your approach to managing Mac's diabetes?
I would tell him that is a very bad idea. But yeah, that actually really limits a lot of our medications options because alcohol, especially binge eating, drinking, could lead to pancreatitis. So a lot of the medication, including actually Jardian's SGLT2 inhibitor as well, in addition to GLP-1s, have that risk. So that will likely not be his regimen. Likely orals, metformin. Again, I would use orals more mainly also just because when they're drinking, they probably are not taking their meds. And so metformin or even like I would sometimes ask them, probably not Jardians either, maybe like the sulfonylureas even would be something I would consider. And sometimes I just tell them, don't take your pills when you're drinking, any of your pills, because any of them could, they are likely to get AKI, acute kidney injury from dehydration when they're drinking. And so any of the like ACE inhibitor, lisinopril, any of those can worsen their kidney functions. So yeah, I likely will keep him on daily Lantus, assuming his blood sugar is still really high, and go for some of the oral options when they are having alcohol use. But I would ask them, are they thinking about stop drinking? You know, like naltrexone would be a great option. Sometimes I do for weight loss monthly. They're monthly naltrexone injections, even though that's not how you use for weight loss. But I would do that with bupropion. And some success. I can't say it's like super successful, but you know, I feel like using one medication for multiple purposes for some of these patients could be helpful.
So I do have some patients who binge drink who are on Ozempic and don't have any like signs of pancreatitis with it. I do educate, like this does increase your risk of pancreatitis. This is what it is. Are you willing to accept this risk, or do we need to look at something else? And I let the patient make the final decision. A lot of them decide to stay on the Ozempic because they'd rather that over the insulin. Other thing, a lot of patients, have y'all noticed that patients on GLPs get sick when they drink? Do you know there are ongoing studies right now where they're using semaglutide as an anti-alcohol drink? I have patients who would not take their Victoza when they went to Vegas because they knew they were going to drink and they would get sick with it. And then they went to Ozempic, and it's once a week, and they don't stop taking it 2 months before they go to Vegas because they go every 3 months, and they just get sick. Well, it actually helped them cut back on their drinking. And then in the process of helping them to Mounjaro, which doesn't seem to have the same effect, their drinking picked back up again. And so now we're playing with maybe going back to Ozempic because of that possible side effect. So it isn't actually in the work. It may help him cut down in drinking. I do give him that heads up. Hey, it may make you sicker if you drink or binge drink with the Ozempic. But I do talk risk with them. Some of them will decide they don't want the risk. I'm going to say most of them decide to go with it because they like the idea of a once a week shot over insulin.
Yeah, I think with the pancreatitis side effect, it is a patient's choice. We do have patients who really like the GLP-1s and they choose to stay on it. Same thing with like their elevated triglyceride, that there is a pancreatitis risk. We just warn the patient, you document it, that the patient is aware, like, and many of them actually want to stay on it with the GLP-1.
All right, let's see. So for this gentleman, we're kind of at the section of the treatment algorithm for patients at risk at ASCVD. And I think Dr. Lin alluded to that a little bit, the ASCVD risk calculator, statin therapy, GLP-1s with proven CVD benefit, SGLT2 inhibitors with proven CVD benefit. So those are all things that we can think about with this case for MAC. Anything to add about ASCVD risk, addressing it, or I think?
I would just say you may see your patients on SGLT2 inhibitors for other reasons. They may not have diabetes, but they're on it because of their heart failure or because of their proteinuria. I always, especially as primary care providers or educators, please warn them about urine infection, yeast infection, and dehydration risk. I feel a lot of times other specialties, when they start them on the medications, they don't talk about that. And so it is very important for them to know, to monitor for symptoms of those side effects.
Also with with the CVD risk, especially in my smokers, I will run their numbers as a smoker and then I run their numbers as a non-smoker. And then I show them those numbers, and sometimes it will convince them to give the cigarettes up and sign up for tobacco cessation.
Do you guys have a pearl when you're starting an SGLT2 inhibitor and they might be on a diuretic? Is there anything you guys might do proactively for dehydration?
Yeah, so I would look at their blood pressure. So if they're still hypertensive, I would just add on the SGLT2 inhibitor without really worrying about their diuretics. But if they're normotensive, then yes, if they're on a diuretic, I would usually half their diuretic. And then usually I don't change the prescription immediately. I would just ask them either cut it in half or just dispense like one time 30 pills of the lower dose and then kind of see. I would say maybe about, for me, has been 50-50. 50% of my patient that I lowered a dose, I had to kind of go back up. I do ask them usually like a blood pressure check at home. If they have blood pressure cuff or go to the local clinic, I would let the BTC people know, like, can you schedule them back in for a blood pressure check in about a week or two to kind of make sure they are still normotensive when you have the diuretic, when you add on the SGLT2 inhibitor.
Anything? Okay. And as our algorithm for injectable therapy mentions, and as both the providers kind of recommended, they were considering GLP-1s or GIP-GLP receptor agonists and transitioning off insulin. Inpatient, it's very common for diabetes to be managed with insulin therapy. But in that transition visit, they're often given instructions for titrating off or making adjustments. And as they alluded to, our patients with diabetes are at high risk for ASCVD. So we definitely want to reduce those risks as well. So not just glycemic management, but blood pressure, lipids, things that have cardiovascular and kidney benefits. We have, I think, so many good options these days for treating diabetes that we didn't have even 10 or 15 years ago. And this guy was 57, I think, in our case. So in the area that he would need, I'd have moderate intensity. I don't think, probably moderate intensity statin, based on what I remember of the case we just went over. But what do you guys have to add? Our mic runners around the room.
And also, I just want to add, like, a lot of times patients come in, you'll kind of also ask them, like, what are their goals? Like, what do they want to achieve? Is it their blood sugar control? And sometimes it's not. Like they, and that's where you can kind of address like their blood pressure, their lipids, and like the other pillars that we kind of talked, stress management, sleep, things that are important to them because they may be very negative or just don't want to talk about their blood sugar because there's so much perhaps negative, relationship with it.
Yeah, sometimes our priorities as like the healthcare team is not the priority of the patients. So I think, when the providers ask what their priority and their goals are, that can be really enlightening and help guide the visit, certainly. Oh, Teresa, thank you.
I just had a comment about the basal insulin dose. So, the standards weren't about over basalization. So in this patient specifically where the bedtime blood sugar is 145 or 151, and then they're already waking up at 131, so like a stable blood sugar. How do you guys talk to patients about their blood sugars being fasting over 130 and then telling them to increase when maybe the problem is actually nocturnal postprandial hyperglycemia? Because that's what I tend to see in practice is that like the fasting blood sugar is elevated, but it's because of nighttime eating. And the basal dose is actually fine if you look during periods of prolonged fasting, but the real issue is postprandial. I find that a lot of people come to me in specialty on these god awful high doses of basal insulin, like 57 units. And then you put them on a CGM and their sugars at dinner are at 330 and they give their Lantus and then they shoot down to 120.
So a lot of our patients are on CGM that are on Lantus, and I will take my computer in for no main reason is so that I can show them and walk through some of their most recent days on the CGM. And if I do see that they're 220 going to bed at night, and then you see that big drop over several hours during the night, and then they're waking up okay, and they're on more than 0.5, especially if they're on more than 0.5 units per kg, then I do talk to them about, we really need to back this off. This is what's happening. If you have a day that you're not eating as much or have increased activity, this really increases your risk of low blood sugars. And we do see that a lot where in the primary care setting, they're pushing the basal, trying to get their numbers down because they're not wanting to start the prandial insulin. I do look to make sure we're trying to optimize those prandials, but also maybe meeting with an RD to come up with other options for bedtime snacking or ways to decrease the bedtime snacking, increase your activity in the evening. My goal is that they're not on more than 0.5 to 0.6 units per kilogram. That means that as they go on Ozempic and lose weight, I am also watching that to make sure we're backing off of the basal to match whatever that weight loss is so that they don't get over basal. If they do hit that 0.5 units per kg and they're maxed out on Ozempic and metformin and they're on Jardiance and we're still having that postprandial, I say, you've got to do something lifestyle wise because it's usually the snacking or the foods, or we're going to add in mealtime insulin.
Yeah, and sometimes I ask them to check their postprandial. I have actually an older patient. That's all he checks. He doesn't check his fasting blood sugar because he knows it's always good. It's the postprandial before bed that he checks.
Sorry, I was just going to make a comment. I feel like a lot of prandial insulin use is used as a threat to patients when a lot of times if you give a prandial injection of 10 or 15 units of rapid acting insulin at dinner or for evening snack, they don't need basal insulin. They do okay during the daytime. So that's just my pitch for not making prandial insulin be punitive because it can be really, really beneficial at a small dose at a specific time.
Yeah,
and then get them away from basal if they don't really need it.
Yeah, so that's exactly what my patient does. He just takes a prandial dose at dinner time, and that's why he checks his postprandial.
I just wanted to add that, like, personally, I don't like prescribing SGLT2 if like their A1C is on the higher end. Because as a pharmacist, I remember the first time I ever prescribed Jardiance, it was a 45-year-old male. I think his A1C was like 10, and he got a really bad yeast infection. And then I just after that experience, I just saw that patients who like had a lower A1C, like maybe 9 or less, tended to get less yeast infections, less UTIs. And I noticed that the higher the A1C is, like the more chance of getting the side effects. So that's just something I wanted to add.
Yeah, so for sure, SGLT2 inhibitor, it is the gradient of your blood sugar, and your kidney is trying to reach a way lower goal sugar. And so, yes, if your blood sugar is in the 300s, you will the patient will be urinating a ton, diuresing a ton. And so we definitely warn them like dehydration and stuff is definitely possible if your blood sugar is so high. However, I would feel comfortable to kind of start them SGLT2 inhibitors. Yeah, because the blood sugar even post-perindu is in 250, 240. So I would still feel comfortable with the random point of care glucose, it was 300. But again, yes, that is definitely possible. And when the blood sugar is higher, you definitely have a higher risk of infection. So your infection-based infection is a lot more common in addition to the medication.
I feel like, Christy, you have a pearl about Jardiance. I feel like when you go through the meds with the patients, you sometimes tell them they're too sweet. Do you have like a rule of thumb for the audience? I heard Dr. Lynn say 250 and these are lower, but if we didn't have blood sugars and we're looking at A1Cs, do you have kind of an A1C?
Yeah. So if I'm looking strictly at an A1C, 9 to 9.5 is kind of my threshold for starting it. Have I started it higher? Yes. And that's usually in a patient who is absolutely refusing or unable to take something else and absolutely refusing insulin. And I'm like, well, I have this, but let me tell you, it's going to put you in the bathroom every hour on the hour, if not more frequently, for at least the first 2 weeks you're on it. And you might as well carry around a gallon jug of water and plan to refill it a couple of times. And they'll start it. And I will say, and here's the diflucan to go ahead and take home because you will probably end up with a yeast infection in the next 2 weeks. And so there's a lot of education if I start it with A1Cs over 9 to 9.5. I will say if I have an A1C in the 10 range with no blood sugars, and I'm anticipating these blood sugars are pushing an average of over 220 to 250 on a daily basis, then I will push for another medication or even use basal insulin to help bring them down with the plan to get the insulin off and add the Jardiance in once their sugars do come down into a better range.
I feel like when we send patients home with diflucan, sometimes we tell them we'll treat one infection. If you get a second infection, give us a call. Any experience with like how many times you might treat someone with diflucan who's on Jardiance or an SGLT2 inhibitor?
I'm going to say most patients twice they're tolerating it. By the third time in the first 6 to 12 months, they're over it and they don't want to deal with it. On the other hand, I've got a couple of female patients that had such an excellent response to Jardiance. They were willing to put up with the yeast infection every 6 to 8 weeks, and we were treating it every 6 to 8 weeks for close to a year, and then no more. She's not had any more, and it's been over a year. We did talk risk benefits. Do we need to try something else? And she's like, no, I feel amazing on this drug. These are the best my sugars have ever looked. I'm willing to do this if this is what it takes, because she didn't tolerate metformin and she didn't tolerate Ozempic. She was in Anchorage. She didn't tolerate Victoza, so I didn't have the access. Some tribal health facilities have the Mounjaro or the Trulicity, but we didn't have that access.
All right. We probably have time for like one more question. If anyone has the burning questions for these really smart women on the stage, we have time for one more. And barring any questions, I will release my providers. Sorry. There is one question. Excellent.
You got me thinking about the yeast infection problem that someone might have on Jardiance, and I was wondering if there was anything you could recommend, lifestyle that they could do to prevent it, or anything at all that would help so that they don't have to treat, or they could help themselves to try to avoid it, even though the medication is the cause.
So you're wanting to, overall, you want to try to lower your sugars. So I'll talk to them about decreasing specifically concentrated carbs or processed carbs. Avoid all drinks that have sugar in them, because that's going to give you a sharp spike in the blood sugar. And now you're going to get an increased dumping of sugar in the next few hours out in your urine. Some women do well with probiotics. With men, I do talk to them, especially if they are uncircumcised, making sure that there's no urine left underneath the foreskin. So they want to make sure everything's good and dry every time they pee, because that the urine underneath the foreskin with that little bit of extra sugar, glucose in there, is going to drive the natural yeast on the skin. They're going to have an infection with it. females, stay clean. Don't use extra perfuming products. Lots of water.
Yeah, lots
Dilute
of water.
the urine.
Yeah,
Lots of
flush it
sugar-free
out. And I definitely have sometimes I ask them like how many times they can shower, because depending on where they are. I have female patient that they have really large folds, like kind of making sure the areas is clean, because they can get kind of yeast infection in like their lower abdomen, like thigh kind of folds as well, if they don't keep the area clean and they're not changing, doing laundry regularly. So those are something else to consider as well.
All right. To keep us on time, I'm going to kick you guys off the stage now. Thank you for playing along.